This is Walter Kemp. This is Arteriosclerosis Part 2. There are 6 lectures on basics of vascular pathology, atherosclerosis, hypertension. This is the 3rd. So this is looking down from the William Wallace Memorial. This is where William Wallace basically took down the English cavalry. He kind of knew the lay of the land there. You can see with the water looping back and that, it was pretty swampy, and he was a very good statistician. Oh, sorry, not statistician, tactician. Sorry about that. So Arteriosclerosis Part 2. There are 2 websites I have. The first one is mine. The first one is, second one is Dr. Hughes. We have a bunch of questions on these. We want to develop more of them, but it's kind of been slow. We'll still work on it at some point and get it going. And they're my 2 Twitter sites. I haven't been active on Twitter for a while, but I do plan to get back onto it with making these lectures, just kind of getting into news with the heme and stuff like that. So, and then remember, I'm a forensic pathologist, but I have a really strong interest in general and organ pathology, especially heart. I really enjoy teaching medical students. Since anybody can view these, I have to have disclaimers on here. These are my disclaimers. You need to read these, and if you do not agree with them or they're not you, then you should not be watching these lectures, so just stop watching the lecture. Otherwise, please proceed. 3rd disclaimer is there, so read that, understand it, and if it does not apply to you, then stop viewing the lecture. But if it's okay, then continue on. And the last one, I made an introductory thing about my teaching style and everything like that. I think about 160 people have viewed it so far, and I think my myocarditis has seen about 3,000 views, so not that popular, but if you're interested in how I teach or anything like that, it's there. Here are the references that I use. I start each lecture out with 1 or 2 questions. The ideas behind this is that it allows you to, as you go through, you concentrate on certain things that were in the question. At the end of it, we'll talk about it. This is a really good way to help people retain information. The idea being that you don't know any of this material, but you look at it and you'll pay attention to the lecture as you go. So pause, try and answer it, or if you can't answer it, and we'll answer at the end. So we'll talk about the morphology of atherosclerosis. So unfortunately, there's a lot of different terms. Some of these are kind of important. Fatty streak is like an early one. So basically, that's literally what you see is a little yellow streak, usually in the wall of the aorta. There's just a few foam cells within the intima, not a huge mass there. And then complicated plaques are very important. Those are plaques that have ruptured or have hemorrhage to it or some acute change. Anytime you have an acute change in atherosclerotic plaque, it's bad because that can lead to potential increased stenosis significantly or even obstruction, and then potentially ischemia of downstream organs, which can be bad if the downstream organ is the heart or the brain or other organs. You'll hear a variety of other terms. These are all just ones that I found. And honestly and truthfully, they probably all describe things, except for vulnerable plaque is also important. Vulnerable plaque is one that is vulnerable to rupture. And I was told when I was at UT Southwestern quite some time ago that they were really very interested in vulnerable plaques. And if they could identify vulnerable plaques, they'd know people are prone to rupture. Because if you have a stable plaque, much less likely for it to rupture or thrombose or anything like that. Can be symptomatic, but it's probably not going to acutely change, whereas a vulnerable plaque could. So I think some of the concepts are important, but whether you use the term fibroinflammatory lipid atheroma or fibroinflammatory lipid plaques, especially at a medical student level, I don't think that's important. I think a lot of them can be just lumped under atheroma, but understanding what's stable, what's vulnerable, and what's complicated would be important to know. Okay, so these are fatty streaks. Top left is an aorta been opened, and you can see basically little yellow, slightly raised lines. Those are fatty streaks. And then to the bottom right, the black arrow shows a foam cell. So the intima, you can see, is hyperplastic. It's thickened, but you can just see the little bit of foam cells. So there's no really good atheromatous core or anything like that. So this is the very beginning of an atheroma. So these are atheromas in the aorta. The left, the larger image, you can see all the black arrows. You can see these visibly raised lesions. Those are the atheromas. For comparison, if you look at the bottom right, that was the fatty streaks I just showed you. So just very slightly, if raised at all or anything like that, very different between the two. So with an atheroma, there's different components. You can see to the right of it, the star is the lumen of the coronary artery. The black arrow is the fibrous cap. So remember, this is what's made by mostly smooth muscle cells that secrete collagen and elastin. And the thicker that is, probably the more stable it's going to be. It's like a dense band of fibrosis, and it's going to be hard for it to rupture. The atheromatous core is outlined in red, and what that is that's where you have your extracellular and intracellular lipid. So the intracellular lipid are where I mentioned the foam cells where the macrophages use their scavenger receptors to pick up the oxidized LDLs and accumulate them. But those can die, and you can release the cholesterol, and you get extracellular cholesterol, which is a cholesterol class. And then the white arrow shows calcification. So within it, you can also see lymphocytes can be a component. You can see new blood vessels formation. You can see evidence of old hemorrhage. You can see hemosiderin from breakdown of red blood cells. You can see fibrin. You can see a whole bunch of different things. And so the atheromas, common locations are coronary, carotid arteries, aorta, popliteal, and femoral. They can occur in other ones, but those are by far the most common ones where you see them. So these just show other components of the atheroma. The top right is the lumen, so you can see very tiny. The red outlines the atheroma, and the black arrow, if you look to the bottom right, that's a close-up of it. And so you can see this chunky yellowish brown material, that's hemosiderin. So what happened is this individual hemorrhaged into that plaque at some time at that location. The red blood cells broke down and left hemosiderin. So atheromas can grow from a variety of reasons. They can grow because of increased production and laying down of collagen and elastin by smooth muscle cells. They can grow by increased numbers of foamy macrophages that have engulfed oxidized LDLs. They can increase because of thrombosis, fibrin that's deposited that then gets resolved. They can grow by hemorrhage, hemosiderin, stuff like that. So there's different reasons why the plaque can grow in size. One thing I showed you with the atheroma, and the other one was the calcification. So calcification can actually ossify. And so if you look at this, the red arrows are showing all these purple areas. So that's basically calcification that's working its way toward bone. So you can imagine this to be pretty stable. That plaque's not going anywhere. The black star is the lumen. So it is obviously very obstructing and producing a fairly significant degree of stenosis. And the person could be symptomatic from this, but that plaque's probably not going to change. So I just put up here, it kind of can show the fatty streaks versus atheromas. Top left is the gross image where you see the little yellow lines again. Bottom left, you see intimal thickening at the bottom with some foamy cells. Top right, all the kind of raised red-yellow lesions, those are atheromas. And the bottom right shows an atheroma in the coronary artery, so you see the fibrous cap. You see the lumen at about 5 to 6 o'clock, and you can see the atheromatous core at about 6 to about 3 o'clock, the lighter area in there. So I use pictures from Montana, Scotland, North Dakota, even Texas, to kind of break up the thing. A lot of students like it. It just takes your mind off pathology for a second. And I like this picture, but I cannot remember where this picture's from. I want to say it's from somewhere around St. Ignatius, and that there's a wetland area there, which I'm blanking on right now, but I'm not for certain. It might not be from there. So one thing that's important with atherosclerotic development is it oftentimes occurs where there's not laminar flow. So laminar flow is very protective against atherosclerosis. Since whenever you get non-laminar flow, so turbulence, that's where you get it. And I think this one highlights it really well. This is a section of aorta that's been opened, and you can see the intima is really rough and irregular. There's tons of atherosclerotic plaque. But if you look at the black arrow, those are branches for celiac superior mesenteric, or one of the other vessels coming off it. Sorry, my anatomy is not quite as good as it used to be. And I have to review, but basically at the ostium of the vessel, you can see plaque. And I think this is a good example. You can see prominent plaque there at that. And you can imagine anywhere there's a branch point or anything like that, you're going to have some degree of turbulence there, and that turbulence contributes to the development of the atherosclerosis. I thought this was a good example of that. So anyway, I was talking about atherosclerosis. I said probably the main important ones you understand are stable, complicated, and vulnerable. Okay, so a stable plaque is like the top left. You can see that plaque is producing about 85% stenosis, so it's probably symptomatic unless they have good collateral flow, but there's no change in it, so it's stable. So right now it's not going to change acutely. Below that is a vulnerable plaque. The star shows the atheromatous core. I've blotted out something there with a blue just not to allow you to be confused, but just ignore that. And the black arrow is the cap. Now, I think there's an actual measurement for what's considered a true vulnerable plaque. And I can't remember if it's like 7 micrometers or something like that. So it was a very thin core, but this is more to illustrate the concept. So what happens in a vulnerable plaque is you have a pretty thin cap overlying a thick atheromatous core, which is exactly what you have in that picture. So you can imagine with that, it's much more likely for that plaque to be able to rupture than if you had a nice thick cap. To the top right of it, this is a atheromatous plaque at the yellow star that is ruptured, which is at the black arrow, that releases the cholesterol, both intracellular and extracellular, and the extracellular cholesterol is the clefts that you see there, right at the black arrow tip. Very thrombogenic, and that produces the thrombus, which is at the black star. And the bottom right is another complicated plaque. You can see there's actually a thin cap there to the right side, but the red arrow is just showing hemorrhage inside the atheromatous core. So basically expanded from the core without actually rupturing the cap or into the lumen, but expanded that plaque so it became much more stenotic to basically in this occlusive because it's kind of pinched off the lumen. So this is a gross appearance of a complicated plaque. So the white the white circle outlines the outer boundary of the coronary artery. The black arrow indicates the lumen. So you can see it's just slit-like in there. And the yellow indicates hemorrhage. So this is basically a complicated plaque where you have hemorrhage into this plaque that's increased its size. And so basically obliterated the lumen. So with atherosclerosis, there's a range of effects you can see. Just in general, you know that atherosclerosis is basically a change in the intima of the blood vessel that's going to produce a blockage, a stenosis. So what that's going to do is affect blood flow. And anytime you block blood flow, you're going to cause ischemia or infarction. Ischemia if the tissue can potentially recover. Infarction once it's dead. It can also contribute to embolism. When those plaques rupture, those cholesterol clefts and stuff like that can get out in the blood flow and end up somewhere else. And then also atherosclerosis will weaken the wall of the blood vessel. It's basically increases the diffusion between the lumen and the wall, and also can place pressure on the vessels and stuff like that, and see a weakening of the wall. And then specific, obviously infarcts can occur in a range of locations. Probably the two more important ones are myocardial and cerebral infarcts. Mesenteric ischemia is also important as well too. And then chronic, you can get peripheral vascular disease, blockage of the femoral, the popliteal, things like that can lead to symptoms, and abdominal aortic aneurysm be a chronic. So the general is just the general mechanisms by which atherosclerosis works, and the specific disease process are below that. So the symptoms and signs they're going to be variable. They're going to depend upon the organ affected. Obviously, the symptoms and signs of a myocardial infarct are different than those of a cerebral infarct. So this just shows one of the chronic processes. This is an abdominal aortic aneurysm, not the same one, but just illustrating different parts. So the top left is basically an in situ. The black box surrounds the abdominal aortic aneurysm. You can see it's kind of raised toward us. And then to the bottom right is an aneurysm that's opened up to show kind of all the atherosclerosis on the inner surface. Then I mentioned peripheral vascular disease. This is where you get atherosclerosis in the peripheral arteries. So like the distal aorta, the iliac, the femoral, the popliteal. And then because of this, what happens is they usually get claudication. So claudication is where an individual is walking, and then because of their walking, the muscles need more oxygen, more nutrients. Because the vessels are blocked, they don't get it. So they develop pain. Individuals stop, and then the pain goes away. That's claudication. It says usually if they have a femoral or popliteal involvement, they get calf. And if they get distal aorta or iliac, that can actually involve the hip. But femoral and popliteal wouldn't involve the hip. Okay, so here's the question. So once again, pause, answer it, and then we'll go over it. So pathology rather than examining microscopic sections from an autopsy, of the following which terms would best describe this lesion in a coronary artery? So this is when I showed you, you can see all the purple is calcification working its way toward bone. So this is a very stable plaque. So this would be a stable atheroma. Vulnerable would be as if it had a really thin fibrous cap, which this doesn't. Complicated would be if you had some type of acute change in it, so hemorrhage or thrombosis. fatty streak. Usually, you think you see them in every vessel. They usually talk about in the aorta, but there you just have a few foam cells in the intima, no significantly raised process. And then a large core atheroma, I just had to come up with 5 answers, so I put that out there. So, but a large core atheroma would be one where you have an atheroma, an atherosclerotic plaque of a blood vessel, and it's got a large atheromatous core. So once again, use reflection, look back on the lecture and go, okay, what are 5 things I learned from this lecture, and go through it. And like I said, this is a really good way. I used to use this in college all the time without even thinking about it. And then now I've actually started using it a lot more again, but it's a really good way. So, and once again, I'm not going to give the answers. That would defeat the purpose because you could just go on to it. And then this is Glacier National Park. So I hope this lecture has been useful to you and you have learned something. Thank you.